I've got 10 o'clock.
Great, whenever you're ready.
All right. So I guess we'll get started to make use of everybody's time fairly. And I'm going to turn it over to Lauren and Michelle from University of Cincinnati and let them get on with this class. Thanks to everybody for attending. This is a first attempt. So off to you guys.
Michelle, you want to introduce yourself first?
Sure. Good morning, everybody. Sorry for my voice. I've got a cold. Not welcome in all this cold weather. But thank you for joining us. Lauren and I are from UC Health, part of our stroke team. I am the System Stroke Program Manager for UC Health. I'm an advanced practice nurse by background. I've been at UC for about 3 years now, and I've been working with stroke patients as a nurse for about 13. So definitely my life's passion work. We tried to make an exciting lecture for you. First time we did this was right around the Super Bowl, hoping our Bengals would go to victory, but I'm still wearing my Bengals shirt. But it's such a great lecture. We wanted to bring it to you today. So we'll let Lauren introduce herself.
Morning, everyone. My name is Lauren Duffy. I am the EMS program manager here at UC Westchester. I have a lot of various other roles around Greater Cincinnati for some committees and community projects, but my home here is at Westchester. I have been a paramedic now for, oh gosh, going on almost 15 years. That is my background. I came from 911 and a couple other hospital systems. So I'm happy to be here today. I love working with Michelle and talking about our stroke patients, and any better care that we can provide to them is a win in my book. So we'll go ahead and get started.
All right, I'm going to turn my camera off so you don't have to see me if I need to wipe my nose. So turn that off, and then I will get this back in PowerPoint mode, and I'll go from there. All right, so we're calling this Monday morning quarterback. So a couple quick notes. There's Lauren's favorite person, Joe Burrow. So not every case we're going to present will be a stroke, just as an FYI. We do give lots of imaging. I know EMS isn't involved in the imaging for stroke, but I think it helps round that out. So I have the chat open on my phone. Please interrupt. We have lots of questions in here. Send us whatever you want in there, thoughts, comments, whatever. We want to hear from you to make this a bit more interactive. The Bengals are totally going to win the Super Bowl this year, right, Lauren?
Well, this was, like we said, when we made this presentation, there was still hope, but as we all know, there is no longer any hope for this year. As we always say, we'll try again next year.
We'll try again next year. It's all we can do. My Notre Dame Irish got beat pretty bad on Monday, so I'm feeling it. Okay, so we'll start with our first case, and Lauren, I'll just click through for you.
Yeah, that sounds good. All right, so our first case here, you respond to a 75-year-old male complaining of waves of dizziness. On scene, you find the patient is sitting on his couch with his wife, and per the patient, he just finished working out. He was lifting some weights, and he had an acute onset of dizziness. The patient stopped working out, and the dizziness continued. He denied chest pain, shortness of breath, abdominal pain, nausea, vomiting, and headache. So here's where we really want you guys to be interactive. Type in the chat, what are your initial thoughts? I will tell you, my first initial thought is, why is this 75-year-old man lifting weights? But he might be a really healthy guy. So what does everybody think?
You can just go ahead and put those in the chat. And cases like this are really hard and it's completely non-specific.
And this can be as simple as, hey, we just think it's an onset of dizziness.
We'll give them this one.
Yeah, we'll Get your fingers ready to type. All right, so your initial assessment, the patient has a strong radial pulse. His skin conditions are normal. His vital signs are as follows. So heart rate is 66, respiratory rate is 16. He's 99% on room air. He has a GCS of 15, and his blood pressure is 173/74. Anything jump out on those vital signs? So what jumps out to me is that increased blood pressure, maybe a little bit high. That could be completely normal for him. Yeah, his heart rate is 66 with that blood pressure. There's a little difference there. And his only medical history is hypertension. So like we said, that initially that blood pressure jumps out at us just a bit, but if he runs normally like that, that could just be his everyday occurrence. He requests transport to Westchester Hospital for evaluation.
I was surprised to see the elevated blood pressure on a dizziness like that. Oh, I'll if I hit the button.
En route, EMS performs a 4-lead. He's normal sinus rhythm. He has a normal finger stick. They initiate IV. They perform a Cincinnati stroke scale, which is negative. They trend all his vitals, which continue to be within normal limits. And the patient still complains of dizziness. So what would your initial impression for this patient be? What would you call in for the hospital? When you're getting a report to the hospital, what would you call in for?
Well, another
ahead,
question
Michelle.
would be, would you call this in as a stroke alert? Would you call this in as a code stroke pre-alert and ask them to take you directly to CT?
All right, we can move forward.
All right, so now we're in the ER, and of course we have a different story for the physician. So dizziness after working out, he had not hydrated prior and fell from the cardio machine 2 hours prior to calling 911. And 1 hour prior, now we've got aphasia. That's new to our story. In the ER, he's unable to follow commands. He's perseverating on being dizzy. So he's just saying, I'm dizzy, and he's just completely distracted by that thought. And he's unable to ambulate. Now we're getting a different picture. Okay. So is this a stroke? And if so, what kind? Throw it in the chat.
Somebody threw in the question and answer section that they lost sound. Can anybody give us a thumbs up if they can hear us, or a thumbs down? Tony says he can still hear us, but I'm not sure about the others.
I'll put it in the chat here.
Tony, I'm not even sure if people have access to the chat. Are we able to check?
Yeah, I'll check, but on the I have a separate system and I can hear you just fine. And I have access to questions and answers.
All right, well, we'll keep going. If you don't mind, like maybe reaching out to somebody that's on, we'll keep going, but let us know if there's any issues.
I'm just going back to my other screen here. Okay. So is this a stroke, and what kind, and what treatment options are available? I'm not getting any response in the chat either.
There's a lot of answers coming through the question and answer section, and they can say they can hear us. So we might not be getting responses, but at least they can hear us. So
okay, good. Yeah, and you can put answers in that Q&A session too, if that's helpful. Okay, so the questions are, I'll go back a slide. Now we've got a little bit of a different story. The dizziness is there. While he was working out, he actually fell. And then an hour prior, the patient had developed aphasia. So that complicates our story here. So in the ER, he's unable to follow commands. He's really focused on the fact that he's dizzy. He just keeps saying it over and over and over again. And he's unable to ambulate. So is this a stroke, and what kind, and what treatment options are available? Look in the chat. Okay. So this patient was given tenecteplase and had an immediate improvement after administration. And there was a stroke. It's right here, this little guy right here in the cerebellum. So this patient had a negative Cincinnati stroke scale, and per protocol probably wouldn't have called it in as an alert. The story seems to have changed, which happens often once they came in through the ER doors. The aphasia with that dizziness, so I call that dizziness plus, that really changes the story. And the fact that he's unable to ambulate makes a big difference. So we wrote brain bleeding. Yeah, and it definitely could have been a bleed with that story for sure. So this patient went back home, completely back to baseline, and I give all the credit in the world to that tenecteplase for doing that. So a quick note on tenecteplase. If you've been working for a while, we always gave TPA. UC Medical Center was part of that initial trial back in 1995 to get FDA approval for alteplase for stroke. It was the first actual treatment for stroke we had ever had. Joe Broderick, our chair, was driving around Cincinnati with a car phone and a leather bag of TPA, giving it out to the hospitals. He even had a license plate that said TPA. He has since changed that to tenecteplase, which I love. So TNK is the sister of TPA. It's more fibrin specific, so we think it does a better job of breaking down the clot. It has a longer half-life, meaning it stays in the body for a little bit longer, which means we can give it as a one-time push rather than having that bolus and that drip, which makes life a lot easier when we've got to transport the patient or we've got other things going on. We're not tying up a line for an hour. It's just a much easier administration, and we're able to give it faster. The indications, the contraindications, the bleeding risk, and the time frame are all identical. This is a genetically modified version. It just works a little bit better, and we can give it faster. Obviously, everything is a risk to benefit conversation with the patient. It is the gold standard, so technically we do not need consent to give that, but we always do. It's always a risk to benefit conversation. Back in those initial trials, the bleeding risk was about 6%, and that's something that conversation we still have with our patients. When we look at real numbers from across the Cincinnati region, including the St. E's hospitals and everybody else, the Cincinnati region runs about 2% bleeding risk. So it's lower. We've just gotten better at finding the patients that this is good for. So we have a pretty low bleed rate. I'm gonna cough just 1 second.
While you're coughing, I always like to add in for EMS providers. So if you're ever getting your follow-ups from the hospital and you're seeing like a major delay post CT to treatment time, a lot of those delays come from those conversations with families. So it is a hard choice, especially if the patient is severely ill and can't make their own decisions. Having those conversations with the family members, it can be hard, like the risk benefit conversations. So if you do see those delays and times, that could be one factor is, hey, we're just talking to the families. Would you guys like us to initiate this medication? There are some risks.
So this was what is called a posterior stroke. The Cincinnati Stroke Scale, which UC created a long time ago, does a really good job of picking up strokes in the anterior portion of the brain, which is the front of the brain. It does not do such a good job of picking up strokes in the back of the brain. So that's the brainstem and the cerebellum. It has some specific symptoms that if you see, it's worthwhile, like this patient, even if your Cincinnati Stroke Scale is negative, giving the hospital a call and saying, my Cincinnati is negative, but my patient had, like this patient, a sudden onset of vertigo with aphasia. That should get you to the front of the line. Posterior strokes typically have a worse outcome, in part because we don't pick them up as well as we do with the anterior strokes. And with the brainstem being involved, you've got a lot of other issues that can come up. So what I call dizziness plus. So a sudden onset of dizziness or vertigo with other neurological deficits. You can have gait impairment. So this patient fell. So I suspect that had something to do with it. So they can fall to one side while they're sitting up, or they walk like they're drunk. They may have clumsiness of their limbs, vision changes, nausea, vomiting, decreased level of consciousness. You can even see hiccups. We saw that a lot in the ICU. Respiratory depression, eye movement abnormality, so that's different than the gaze deviation, ringing in the ears, and trouble swallowing. So you can see that the Cincinnati Stroke Scale and the FAST exam have a really hard time picking this up. For community education, we've moved to BFAST in order to help folks pick these strokes up a little bit better. So I love this picture. This is a live brain rather than a cadaver. So your basilar artery coming up through here, your vertebral arteries going along the brainstem. This is such an important vessel because it feeds that brainstem, which controls so much of what our bodies do. A clot in there is very, very dangerous. So it's important to pick these symptoms up, even if our tools don't necessarily do a perfect job of picking them up. And the cerebellum, this little mini brain back here, has a lot to do with our balance and our gait. So any alteration in that could be the sign that you're dealing with a posterior stroke, especially if it has a sudden onset. So something just to keep an eye out. This patient was difficult. I heard he was dizzy, 75, he's working out. Cincinnati Stroke Scale negative. Wouldn't necessarily be my first thought that it was stroke. His pressure was up, so that was a bit of a clue. But that's definitely a difficult case, especially if you're not getting the whole story. So if you can put it in the Q&A or the chat, wherever you want to, and did you think this patient was a stroke initially? And what were the clues? I guess I kind of answered this. So I think that sudden onset, dizziness, and then that elevated blood pressure. The brain tries to perfuse itself when it knows there's a clot there. It'll turn the pressure up, just like you do on a water hose that's clogged or you're stepping on it. It turns that pressure up. So that was a bit of a clue. But with the story you were getting, I wouldn't necessarily think stroke right away. Obviously, we've all been there. I've done it as a nurse. I've done it as the advanced practice nurse. They tell me one story and they tell the doctor something else, and then I look stupid. But that's why it's so important to have that next of kin information so we can call them. And the symptoms can evolve quickly. So even if there's nothing there at the beginning, you can see things evolve pretty quickly, especially if it's dealing with the back of the brain. Okay, Lauren, our second case.
All right.
Great picture.
Does anyone know who is that in the picture? I'll take some guesses.
My husband would be really good at this question.
Well, for those of you who don't know, that is Icky Woods. In the picture there, this was a commercial that came out a while ago. He's actually in Kroger, so.
Perfect for this case.
And I muted myself accidentally. All right, so you respond to Kroger for a 65-year-old male for a witness seizure. On scene, according to Kroger staff, the patient seized for approximately about 5 minutes. The patient has a bloody lip. He's not completely alert. He's really sleepy, hard to arouse, but he is able to nod yes or no. What are your initial thoughts for this patient? Do we think he's just postictal? Do we think he's just sleeping?
Rough day to have a seizure in the Kroger.
Rough day. All right, so our initial assessment, the patient remained sleepy. Unknown medical history, we couldn't really get him to answer. His mental status kind of remained the same, and he was transported to UCMC. En route, no interventions were completed, no vital signs were obtained. Patient was left to sleep. So
somebody asked about a seizure history.
yeah, so we couldn't get it. This crew couldn't get any history on the patient. The patient wasn't really arousable, really sleepy. No, they didn't have any family members with them at Kroger. They really couldn't get any good information. Now, en route, if we don't have a history, what else can help us kind of determine what we're dealing with, right? Our interventions and vital signs. So what should we have done for this patient? Yeah, I like this comment
vitals
too.
Would have been great.
Yeah, set of vitals would have been awesome. Maybe a finger stick blood sugar. All right,
Yeah,
go ahead, Michelle.
definitely a blood sugar would have been great.
So without that history, without those vital signs, I guess our initial impression kind of remains with our initial thoughts. We just think, hey, this guy's probably postictal, or he's just sleeping. Let's let him sleep. Not the right answer, but
yeah. All right. So now we're at the ER. We're postictal upon arrival, but we're following commands now. We're protecting our airway, removing all of our extremities. And the nurse said he quickly returned to baseline and was now able to talk. So we're doing great. Yeah, the comment in there, that's great. The 12 lead the vitals. Exactly. 1 hour later, we've had another seizure. Now it's witnessed by the nurse. It's lasted less than 1 minute. Treated with Ativan, then we had a sharp decline in our SpO2. So maybe a seizure disorder we don't know about. Oh, there it is. History of seizure and a history of a left hemispheric intracranial hemorrhage that actually caused a car accident in 2019. Story as old as time with a patient that self-discontinued their seizure medicine and no longer followed up with neurology. He doesn't have any other seizures in his medical history, and they suspect that the bleed that he had in 2019 was because of hypertension. So a blood pressure en route would have been helpful if that may have led to that or what else we were dealing with. So we scanned him and there's a bleed. We've got a new bleed, right intracranial hemorrhage and the temporal lobe. Would you have suspected that this patient was a hemorrhagic stroke? And would that have changed your patient management in this situation?
it's hard to suspect that we think it's hemorrhagic stroke when we kind of didn't really do any assessments or vitals. But I think if you did have that slight suspicion, it definitely would have changed your patient management, right? Obtaining vital signs, checking that blood sugar, kind of going down that stroke pathway. At least starting an IV.
Lauren Tony said there's a bit of a delay, so we can give it a little bit longer.
Okay.
For them to respond. Even having worked in stroke my whole career, I don't know if I would have gone straight to hemorrhage with that patient. It's certainly an option, but other things like, is the sugar too low? Is the patient overdosing? Without family there, without it being witnessed, it's really hard to know what's happening there. But I think a blood glucose and vitals would have helped a lot in this situation, even if the patient's not able to respond and we don't have any next of kin. So something to remember about seizures. Seizures can be a primary seizure disorder or the symptom of a larger issue. So is there blood in the head like this patient? Is there a really big ischemic stroke? Is there a trauma? Is there a lesion? Is there a tumor up there that we don't know about? So to obviously treat the patient that's in front of you per your protocol and try to gather as much history as possible. Difficult on a patient who's not responsive, but at least some information would have been helpful in this instance. Any comments on that one? I don't see anything here. Okay, we'll head on to our next case.
All right. So you're dispatched to a 63-year-old female for possible stroke. On scene, you find a patient who's with her family. Per the family, patient was found on the bathroom floor after not showing up for her job. She has left-sided weakness along with left-sided facial droop, and her last known well was the night prior. What are our initial thoughts for this patient? So yeah, I think our initial thoughts could be that dispatch of the possible stroke, but a couple other things come to my mind. Could this be some type of trauma post-fall? Could she be in rhabdo? Being on the floor all night, having some muscle breakdown?
Yeah, that's a good thought. I hadn't even thought about that.
So initial assessment, patient's vital signs are as follows: heart rate of 84, respirations of 18. She's 97% on room air, and her blood pressure is 162 over palp. Patient's only medical history is hypertension, and the family requests transport to UCMC for evaluation. Anything jump out on those vital signs?
To me, she doesn't seem to be in like an immediate distress situation. Vitals are pretty good for somebody who's been laying on the ground for that long.
Yeah, for sure. So en route, her finger stick blood sugar is 188. They initiated IV. And they performed a Cincinnati stroke scale, which was positive for that facial droop and abnormal speech. So what is our initial impression for this patient post vital signs and a couple interventions?
I think definitely worthwhile calling this in as a pre-alert for sure.
Yeah, I think this is one of the ones that really jumps out. Hey, call in that stroke alert.
Yeah. All right. So the ER physician, the last time done well was confirmed to be the night before. So when we look at that last time done well for these quote unquote wake up strokes, the questions to ask, even in the field, is did anyone see them overnight? So kind of the running theory is that the stroke wakes these people up. So there's the potential that, you know, the stroke happened a little bit before the patient woke up. So we always ask questions like, did they get up to let the dog out? Did they get up to go to the bathroom at some point that somebody saw them and they were normal? Those kind of questions. Somebody put in the chat, is she out of time? And that's exactly the right answer. Looking for that last time, no, normal, and her blood glucose is very high. So that's where you guys can really help us, is kind of asking those questions for these patients that, like, you know, I woke up and my husband got up to go to the bathroom and I walked in after him and I noticed his face was drooping and his arm was weak, and kind of those, you can get additional information to see exactly if there was a point overnight where they got up and were normal. That really helps us a lot. So the daughter spoke to her on the phone that morning, but there was conflicting reports of whether her speech was already abnormal. So that just adds another layer of confusion. She's no known anticoagulant use, and she's independent at baseline. Additional information that's super helpful for us to know, especially if you're seeing the next of kin when you show up at their house. So in the ER, she's got left-sided weakness, a facial droop. Her eyes are deviated to the right. She has a visual deficit, so she's got some vision loss, and she's neglecting. So she's neglecting one side, and she's having some trouble talking. Is this a stroke? And if so, what kind? And what treatment options are available? Think about the symptoms we just listed. Is a big clue, and you'll see it in your protocol. So obviously it's hard. Oh, we got a new one. LVO, yes, exactly. So we think, obviously we need a CT to verify it. It's impossible to know, even if you're a neurologist, whether it's a hemorrhagic or an ischemic without a CT, but this list of assessments is pointing to a large vessel occlusion. So almost all strokes have weakness. A lot of them have a facial droop, trouble talking, things like that. But this gaze deviation, the neglect, and the visual deficit are all glaring signs that there's a large vessel involved. We've got the CSTAT, also came from UC Medical Center. It is quite good at picking up large vessel occlusions. But if you see things like that gaze deviation, so we're looking off to one side, they're unable to cross midline, and they look towards the side of the stroke. So it's going to be opposite of the weakness. So we have left-sided weakness, but our stroke is in the right side of the brain, so our gaze is deviated to the right. You walk up and see that in a patient, it's time to call in that you've got a positive CSTAT. The visual deficit loss is challenging to pick up, but with that there and neglect, this is a kind of classic large vessel occlusion. Very good. Does the last time known well impact this? Because this is a wake-up stroke. We've got confusion from the daughter. Maybe her mom was fine when she talked to her on the phone. So no one has really seen her since the night before, so that's got to be the time that we go with. We're definitely not within 4.5 hours. And would you treat this patient? I know that's a lot of questions. But I think this kind of helps, these questions kind of help you see kind of the conversations that we're having in the ER and with the stroke team of kind of trying to quickly kind of put these patients in buckets of ischemic or hemorrhagic, what treatment options are available, which ones are they eligible for, and then having that risk benefit conversation, offering them all the options possible. So here's our imaging. On the left is a CTA. See my little cursor here. You're looking to see if things look the same on both sides. Oh, lost it. Here you go. And the dye is not able to get through this vessel. So we've got a clot sitting right here. Because this was a little, we're a little unsure of the last time known well, we did what's called a CT perfusion scan. This is an AI software called Viz. This is at all the hospitals in the Cincinnati region, St. E's. We all work on this together. So on here, it actually maps out what tissue is left to save. So here in the red is the necrotic core. This is dead tissue, dead brain, nothing we can do about it. But when you look at the green, this is the penumbra. That's Stroke's favorite word. This is the tissue that's not dead yet and has the potential to be saved. Even though there's the potential that she had this stroke the night before, if she has a lot of collateral vessels, or what one of my doctors calls it, backdoor vessels, that are helping to try to keep this brain alive, look at all this tissue we have the potential to save if we go in and try to get that clot out. So this software doesn't replace radiologists, it doesn't replace stroke neurology, but it very quickly, within a couple minutes, gives us a tool to make that decision and do what's best for the patient. Because if all the tissue's dead, there's no point in going in. So when the story is a little iffy, these tools just give us additional information to make the right decision for the patient. And this goes to the phones. So this, I get on my phone, all the stroke neurologists have it, and they can look at this within a minute or two, regardless of where the patient is. If that's St. E's, anywhere, they're able to see this. It's been a great tool for us. So patient did not get TNK, and we saw that there was that occlusion. So we went in for that emergent mechanical thrombectomy. And the MRI after the procedure, probably the next day, did show that infarct right here. Stroke shows up white on MRI. So it looks like a decent sized stroke, but this could have been much, much larger. We go back here, you can see that this green, what was at risk. This is a huge area of your brain that's almost kind of half of it in the cortex there. So this really helps that patient minimize the disability that they have. So just a reminder, I think everyone's pretty familiar with this. So mechanical thrombectomy is physically removing the clot. Think of it like the cath lab, but for the brain. So we go in through the groin, take a catheter up to the brain, have one of these stent retrievers here, kind of set it there for a couple minutes and let the clot adhere, and or with a little suction catheter and kind of like a straw, just suck the clot out. These clots are small, a couple millimeters, but they cause just an insane amount of damage. It's amazing how much damage such a small thing can make inside of our brain. This patient was eligible for this procedure because we can take patients up to at least 24 hours after the last known normal. That's why the protocol had you call stroke alerts out to 24 hours. I'll tell you this UC thrombectomy, guys, we're going past that point. We're doing it on a patient-by-patient basis. We're willing to push that envelope if there's something there to save, if it will help the patient and the family's on board with it, we're going to go for it. So we do push that envelope because that it's just not a hard and fast rule anymore. We have a lot more patients that we can help. You can't do this in conjunction with TNK. It's kind of the best case scenario. Little TNK, start dissolving the clot, and then go after it with these stent retrievers. Obviously, advanced imaging, there's some conversation about functional status, but we're kind of pushing that envelope too. But this has been a game changer. A lot of trials came out in about 2015 to really show the benefit that this has. And the faster we do it, the more brain we save, the better outcome for the patient. So if you've never been inside one of these suites at St. E's or UC, It does look like a cath lab. We've got these x-ray machines, these C-arms, and we're injecting dye and we're taking x-rays and we're able to pinpoint where that clot is. We've got the CT as a guide, and then we're able to find that clot and go get it. Once they're in the groin, and say the patient's vessels are nice, they can get up there within just a couple minutes and grab that clot. So it's such a game changer. We can't just keep giving TNK or TPA. It increases that bleeding risk for these large clots, so we just go in and grab them. A little bit busy slide, but all of these vessels is called the circle of Willis. Here's our basilar artery, middle cerebral artery. So, you know, we're really good at getting these middle cerebral arteries, the carotid artery, the basilar artery, but you can see all of these are completely coordinated to a specific part of the brain. And so that's how, based on where the clot is, we can really tell what symptoms their patient's going to have and what area of the brain is going to be impacted. So this patient had some carotid stenosis. If something broke off and went up, caused all kinds of problems. So they got a stent during their admission. And Jason Kelsey's pump too. This patient went home completely back to baseline. Even with this stroke, this patient went home back to baseline. You know, obviously you can't save dead brain tissue, but the brain can make new connections. So that's why physical therapy, occupational therapy are so important after a stroke. The brain continues to learn, it continues to make new pathways. So we never tell stroke patients like this is as good as it's ever going to get, because there's always an opportunity to get better. But the faster we get them treatment, the better we'll do. So this patient, you guys pointed out, was an LVO. So just a refresher on the Cincinnati, the CSTAT. So this patient had that gaze deviation. So they were looking towards the right, towards the stroke. That is an automatic positive CSTAT. So you did your Cincinnati stroke scale, that was positive. Then you moved on to your CSTAT. That gaze deviation is there. You're going to the nearest thrombectomy capable center, because it is so much faster to take the patients directly there. We've got a couple level of consciousness questions and command questions there. That's kind of looking at language, and then the arm weakness you've already done in the Cincinnati. But if that gaze deviation is there, we're looking at an LVO. Lauren, I'll let you talk about the stroke sticker.
That sounds good. So our partners in Northern Kentucky, so St. Elizabeth, and then most of the greater Cincinnati area hospitals work together for the Greater Cincinnati Stroke Consortium. And one of the projects we had was to basically end the game of telephone from EMS to the receiving nurses in the emergency department to admission all the way through discharge. So this EMS stroke alert sticker was created, and it basically has all the information that we need to know in order to have those crucial conversations with family and get these patients the correct treatment. So this sticker gets put on by you guys. So it gets filled out on scene. You're already obtaining this information anyways. So while you're putting it, like say in your Tough Book or your iPad, whatever you guys use for your documentation, have somebody fill this out. This sticker is a cling material. So once you put it on the patient's clothes, this can easily be transferred once we get the patient into the hospital and have them changed into a gown. So once we get them changed, we peel off the sticker, put it right back on their gown, and this stays with them through the entire stay all the way through discharge. One of the most important things I think on the sticker is that witness contact phone number. So we know a lot of times families can't ride with us. They usually have to, make arrangements at home before they get into the ambulance and get to the hospital. So if you can have that witness contact phone number of somebody in that patient's family that we can talk to, that really prevents those delays with those crucial conversations about treatment options. This also includes, the positive Cincinnati pre-hospital scale, the CSAT score, finger stick blood sugar, and then it also has our blood thinners on it. So is the patient on any blood thinners? And I don't know about you guys, but I have a really hard time keeping an index of pharmacy in my brain. So I always think this is super helpful reference when you're looking at a patient's med list. If any of these meds pop out, you can go ahead and check these. My favorite part about this sticker is this is a really useful tool for when you are calling in a stroke alert. You call the receiving hospital and you say, this is medic so-and-so calling in with a stroke alert. Here's what I got. Everything that's listed on this sticker is what we want to know on the phone. You can kind of just use it as a guide as you're making your notification call. But we really encourage the use of these. We see really good outcomes with these stickers. They're super helpful. Some of our neurologists even say, they've gone into a patient's room and they want to have a conversation with the family, but the nurse isn't there or there's no other attending there. They actually just look at the sticker, pull out their cell phones, and make those calls themselves.
Yeah, this has been a huge thing. Like our IR guys, when they come, so we do the initial assessment, patient gets their CT, they talk to the stroke team, we're suspecting LVO. Our IR guys they're getting alerts because we've got those AI tools like, oh, we might have a patient. They come running into the ED, the nurse has walked out to do something and they want to get this patient consented and moving. These have been huge for them because they don't need anybody. They can just go ahead and call the family member straight from the sticker. So the Greater Cincinnati Stroke Consortium is all of the hospitals in the Cincinnati region. We come together once a month to meet at UC Health to have conversations, to plan events. We do a strikeout stroke at the Reds. We have a big consortium. We've a big educational offerings. We do survivor dinners. We do survivor picnics. Just a lot of events that just help that stroke community. And regardless of which health system you work for, we all work together to make sure that everybody in Cincinnati and Northern Kentucky have exactly what they need to do what's best for the patient, and then the patients feel supported regardless of where they go. So this sticker's gotten a lot of national attention. I've seen it pop up at different presentations at conferences, and I'm like, wait a minute, that's from Cincinnati. So it's been exciting, and I think we've seen some other places start using it. Something we're really proud of. So definitely worth using. I know it takes a couple more minutes, but it really does help us move things a lot faster once they're inside the hospital. And we appreciate you guys using them.
Yeah, and if you ever need more, just contact your local EMS coordinator. They can get you guys set up with some more.
All right, we're in the fourth quarter.
All right, so you respond to a 66-year-old female not responding, facial droop, now unconscious, with hand paralysis, history of strokes, and now she's possibly seizing. And that is actually the dispatch that we got from Hamilton County. So on scene, you find the patient in the front seat of a car in a parking lot, sitting upright but unresponsive. Patient's husband on scene stated his wife has history of strokes, with her last being within the last year. So what are your initial thoughts for this patient? I mean, that is a complex dispatch.
That's a tough one with, is she having those symptoms because she's having a seizure? Is it because she's having a stroke? She's unconscious, but she has a history of stroke. That's really, really complicated.
All right, so with your initial assessment, the patient has a strong radial pulse. Skin is diaphoretic. She's not responsive to painful or verbal stimuli. Heart rate is 64, respiratory rate of 25. Her GCS is 3, and you are unable to obtain a blood pressure.
Yikes.
Patient has that medical history of hypertension and strokes. You guys removed her from the car and she remained unresponsive, and she was transported to UCMC for evaluation. En route, They did a repeat set of vital signs, heart rate of 67, respiratory rate of 27. Her GCS has improved a little bit to 7. And then her blood pressure, which is now obtainable, is 180/70. They performed a 4-lead and a 12-lead. She showed no sign of STEMI. Her fingerstick blood sugar was within normal limits. IV was initiated. They did perform a CStat score on this patient. So she scored a 2. She had no eye movement, left fixed deviation, answered age incorrectly, and she had arm weakness. So with a CStat score of 2, blood pressure, her initial complaints, the initial dispatch, she became more responsive during her transport, but then she stated that she had a sudden and severe headache. What's our initial impression from all that we gathered?
This is a complicated one for sure. No wrong answers. Just go ahead and throw it in the Q&A.
And if you don't want to give that initial impression, what stands out to you the most from this, from what you gathered en route?
They wrote a bleed.
Great.
So now we're in the ER. Patient is hypertensive. She's in distress from the severe headache. She will not move her lower extremities. No fever, and sent to a stat CT. I think your bleed assessment is correct. So this is a subarachnoid hemorrhage with interventricular extension, and she's got some obstructive hydrocephalus. So you can see this, it's not like the other bleed where we had that blood sitting right in the brain tissue. Now we're what I call the nooks and crannies. So you can see it kind of here in this outline. And then here in our ventricles, you see blood sitting in there. So we've got what's called a subarachnoid hemorrhage. It's kind of around on the outside of the brain. All this white through here. When you see that pop up on a CT, we kind of know what we're dealing with there. So this blood is going to block the ventricles from draining the CSF fluid. So after CT, this patient quickly had a decreased level of consciousness. She vomited and required intubation and did require an emergent EVD placement. These patients will turn on you very quick, and you could see how quickly, when they first got called from that dispatch, how quickly she progressed and how quickly she changed. So we did a CTA, we found an aneurysm, and that's what caused this subarachnoid hemorrhage. Once we see that on the initial CT scan, then we start looking as to what caused it. Oftentimes it's an aneurysm. So our subarachnoid hemorrhage, we kind of talked about this already, but that first bleed we saw was an intercerebral hemorrhage that's bleeding directly into the brain tissue itself. That patient had that because of their hypertension. This one, you see blood all around what I call the nooks and crannies of the brain, and then here in the ventricles. And then that was from an aneurysm rupture, which fills this up. So we said this patient got an external ventricular device or an EVD. These can be placed in the OR or just at the bedside, especially emergently. And it's a drain placed into those ventricles that helps us drain out that blood. Because the skull is a fixed structure, so obviously swelling isn't going to be great. It's not like an abdomen where the skin can stretch. If we let that blood sit in there, we let that CSF build up, we're going to have a herniation that patient's going to pass. So this drain is placed in the ventricles and it drains that blood and extra CSF off. And it also allows us, you can see it over here, hooked up to the monitor so we can monitor intracranial pressure. It also lets us kind of set the level of the EVD so we can control how much blood or how much CSF is draining off, because we don't want to drain it off too fast or too slow. And we can really monitor that with a very simple drain that can be placed at the bedside. So this patient went to IR for a pipeline stent. This is kind of a reconstructed image, but here it is, that little kind of ball thing you see right here. And you can see we're kind of near that arrow right here where that aneurysm is sitting. Again, small vessels, but man, they cause a lot of problems. So for the aneurysms, there's different treatment options. These are getting better and better every day. You can put in what's called, a coil here. Excuse me, I'm gonna cough. You can put in a coil here, which helps stop blood flow from going into that aneurysm, and that will shrink and kind of reabsorb. If it's a large, kind of wide-necked aneurysm, you can go in with neurosurgery and clip it. I think of this as like a chip clip. You just clip that off so it can no longer get blood flow through there. This is done by the same guys that do thrombectomy, this one, and they can go in through the groin. This is done with neurosurgery. Then this one, this is what this patient had, a pipeline stent, which again just stops blood flow through here. And sometimes it's a combination of these two, but the devices and the technology just keep getting better and better to treat these aneurysms. I had to sneak a Broncos picture in here because my husband's a big Broncos fan, so I apologize for that. After several days, this patient wasn't able to be extubated, and they removed the EVD, but they did require a permanent VP shunt. And the patient was able to discharge to inpatient rehab with just some mild confusion. History of Alzheimer's, so it was a little bit baseline, but typically these patients don't have a great outcome. That blood in there is very toxic. It does a lot of damage. Sometimes the body will respond to that blood by kind of vasospasming or shrinking the vessels, and then that causes ischemic strokes on top of everything else. So these patients have a pretty high morbidity and mortality rate. This patient had a fantastic outcome. We caught it quickly, controlled the pressure, dealt with the aneurysm to prevent that to keep bleeding. And she was able to go to inpatient rehab. And that's such a great outcome because I've took care of a lot of these patients when I was in neuro ICU, and not everyone is so lucky. So hemorrhagic stroke symptoms, again, we can't tell the difference without a CT scan, which is why we have a mobile stroke unit. We can just do that in the back of that. These patients can look identical to ischemic stroke. So the BFAST, it can look exactly the same. One clue, and this patient had that once she kind of came to a little bit, is that extreme headache. Like I said, the skull is a fixed thing. It can't expand. So all that extra fluid in there is going to cause pain. You may have patients say, this is the worst headache of my life. They may describe it as a thunderclap inside their head. Light sensitivity, neck rigidity, very similar to meningitis, because it's that blood is irritating those meninges. Nausea, vomiting, like some have like projectile vomiting. They can have really extreme hypertension. You'll see hypertension in ischemic too, but you can also see that in hemorrhagic. They can have changes in their level of consciousness, and then respiratory depression. So if you've got a patient who's got the stroke symptoms and they've got the headache, keep a good close eye on them because you may have issues with your airway. You may lose consciousness. So she was kind of varying in her consciousness. She may have had a seizure from the blood. That can happen too. So it happens quick. As soon as that aneurysm ruptures, you've got symptoms and they can deteriorate really quickly. So keep a close eye on them. Were you surprised by the final diagnosis of this patient? From the initial story, from what dispatch got, a little bit. It sounded like maybe it was not quite stroke related. Maybe it was a seizure. Could have been any number of things. So hemorrhagic strokes require just as immediate assessment and treatment as ischemic strokes. I'd say our management of these patients is not as standardized as ischemic stroke, but there is a big kind of international push to do so. UC was just part of the writing committee for American Stroke Association to put out metrics to monitor how ERs are taking care of their hemorrhagic stroke patients, because these patients have high morbidity, high mortality. They're only about 13% of strokes, but they take up a ton of resources and they don't do well. So UC is part of that writing committee to really push this to make sure that across really the world that we're doing a better job of taking care of these patients. Top priorities, blood pressure management. We want to do it nice and slow, get them to a good rate. If we drop them too fast, then we have issues. If we let them run high too long, then that blood is going to continue to squirt out. We don't want you to control blood pressure in the field because we don't know, one, if it's an ischemic or hemorrhagic, and oftentimes if it's an ischemic, we'll let it run a little bit higher. So until we have that CT scan and we really have a good plan, we want to leave that blood pressure alone. If they're on an anticoagulant, we want to reverse it. That's one of our top priorities on this. But again, we won't do that until we have an idea of what's in that CT. Like I said, they can deteriorate really quickly. They may not protect their airway. So if you suspect you may have a hemorrhagic stroke, get them to a center quickly and just keep a close eye on them. All right, last one.
All right, so you guys respond to a 45-year-old female, possible stroke. On scene, you find the female sitting on a bench. She's alert and oriented ×4. Patient stated that she was on a walk about 15 minutes prior. Then her entire left side became numb. What are the initial thoughts for this one? So she's just walking, her entire left side goes numb, but she is alert and oriented.
I think more questions than answers on that one.
Yeah, could she be a TIA? Could she be a full-blown stroke? Could she have some Bell's palsy issue? All right, so initial assessments, the vital signs are as follows. So she had a heart rate of 86, respirations of 16. She was 96% on room air, and her blood pressure was just 135/94. So nothing crazy. Do immediate stroke? Yeah, weakness for sure. The patient had a normal breathing, patent airway. Her skin was pink, warm, and dry. And the only medical history she has is actually previous strokes in 2020 and then hypertension. En route, the Cincinnati Stroke Scale was performed due to that weakness. The only deficit noticed was that weakness in her left side. She had a weakened grip. She still endorsed that numbness en route. IV access was attained and she was transported to UCMC.
Yeah, someone put in there with you want to do your stroke scale.
Yeah.
For sure.
So yeah, our initial impressions, we hear weakness and we're thinking, hey, possible stroke. Let's do that stroke scale.
And too, interesting that, she didn't really complain initially of that weakened grip. She was complaining more so of the numbness. So even if it's not, that you walk up and it's so clear they can't lift their arm, just even that weakened grip is something to look out for, even if it's kind of minor like that. So sudden onset, left-sided weakness and numbness prior to arrival with stroke. Sudden onset is the phrase to say everybody excited. The brain, I like to say she's a bit dramatic. The second that oxygen gets cut off, your symptoms appear. So it's not something that, if you have heart problems, kidney problems, they can kind of coast for a while before we really start to see symptoms. The second that oxygen is cut off, we've got symptoms. So that sudden onset, when I hear that, my ears perk up. So on the CT scan, they found an old stroke, which she had mentioned she had a history. The CTA was negative for a large vessel. And her symptoms, we've got that dysarthria, mild facial droop, a little bit of weakness, a headache. Doesn't necessarily, we wouldn't say that's a positive C-stat on there. So don't suspect an LVO. She's had, we dig into the chart. We're able to see that she's had prior hospitalizations for stroke-like symptoms. She's gotten TPA before. Her MRI has always been negative. And she's got a history of PE and DVT and hypertension. And she's not taking any anticoagulants. That's kind of a recipe for disaster there. So she's 45. We're already clotting. We're not taking our anticoagulants for one reason or the other. And we've got a hypertension. So, really all the risk factors for stroke there in one list. So are we thinking this is a stroke? What kind are we worried about? And what treatment options are available? I already said probably not, it's not an LVO, so we're not doing thrombectomy. So our option is tenecteplase if we think it's ischemic. And that's what we did. We did tenecteplase. So she had an immediate improvement after the tenecteplase. Always great when that happens. Like, just makes your whole week, you feel like you're a miracle worker. It's great. I'll tell you, tenecteplase doesn't always work that fast. Sometimes it takes up to 90 days to really see any improvement with tenecteplase. So if you hear back from St. E's, you hear back from us that, the patient went home with a similar deficit after getting tenecteplase, it doesn't necessarily mean it didn't work. So all the hospitals that do this, we call the patient at 90 days to see how they're doing, because it can really take up to 90 days to see the full effect. But man, when it happens right away, it's the best. We did an MRI. It's actually there's no stroke there. It's a little bit surprising. She has a history of heavy alcohol use. We've got her on a CWA scale. They found MRSA in her blood cultures, and she's also got a positive UTI. So our MRI is negative. We had stroke symptoms. We've got all the risk factors, but the MRI is negative. So now we have to start thinking. She had a headache. Could this have been a complex migraine? A complex migraine can give you stroke-like symptoms, and it's a big mimic for stroke. Is this a functional disorder from stress? She's got an alcohol use. Is there something else going on in her life? Does not mean that these symptoms aren't real. It means this is the brain's way of presenting that stress and dealing with that stress. Functional seizures, the verbiage changes often. And we tell patients, like, we don't think you're faking it. This means that this is your body's response to that stress. Or was it a TIA? Did the clot happen and they were able to resolve it? Or did the TNK work so fast that there was no permanent damage on MRI? That's called an aborted stroke, and that can happen. She's 45, maybe she's got great collaterals. It's hard to tell. These are kind of our list of options. Fortunately, she left AMA and no-showed all of her follow-up appointments. So a bit concerned about the MRSA in the blood cultures and the UTI, and hopefully she's doing well. She has a lot of history of clotting and everything else that I hope she found care somewhere else. But it's one of those where we're just not sure. It could have been a mimic. Could have been we did such a great job. We were able to get the clot. It's just a complicated case. Would you do anything differently knowing the outcome? I wouldn't. I wouldn't do anything different. I would have given her the tenecteplase because it looked like a stroke. She had a history of stroke. She had a history of clotting. She was not on anticoagulants. She had a history of hypertension. So the risk for permanent damage was really there. There is a low risk of bleeding after thrombolytics per mimics. it runs between 0 and it's really less than 1%. So the risk is much higher to not give a stroke treatment than give a non-stroke treatment. So we want to not give it unnecessarily, but we don't want to too quickly rule people out. Etiology, like I said, can be really difficult to determine when the imaging comes back negative, but the risk factors were present, and she also had all that infectious stuff going on too. Time-sensitive diagnosis, so MI, stroke, sepsis, those are time-sensitive. Time makes all the difference to patient outcomes. Always call the alert, even if you're not 1,000% sure, because we can always de-escalate. If you call a stroke alert and it ends up not being that, the only thing the patient got was a CT scan. They're going to get one anyway if they're having any neurological issues. They just got it quicker in the process. There's nothing worse than getting a chart sent to me and looking to see that everyone through the process is too afraid to call the alert. And then the patient gets missed, and then all of a sudden they've got a big stroke on MRI. I'd much rather be wrong and it's not a stroke than be too afraid to call it. And we tell our nurses the same thing about calling inpatient alerts. We can always de-escalate. It's not a big deal. So Tony sent a text that asked about the Cincinnati stroke scale and the CSTAT before we go on to this. Lauren, do you want to walk through the Cincinnati stroke scale, the FAST? And I'll go back to the CSTAT picture.
Yeah, give me just a second.
Yeah.
All right, guys, sorry, somebody popped in here. All right, so we want to talk about the Cincinnati stroke scale. So we're looking for a couple things, if positive. So we're looking for that facial droop. Ask the patient to show their teeth and smile for you. Do you see any deficit on one side or the other? Then we're looking for the pronator drift. So you're going to ask your patient to extend their arms out with the palms up with their eyes closed. Watch to see if one of their arms drifts down. If one arm drifts, the test is positive. If both arms drift down, that's kind of like an unclear result. But if you have one that starts to really weigh down over the other, that's a positive. And then we're looking for that abnormal speech. We're going to ask the patient, you can say, the sky is blue in Cincinnati. If you have any abnormal speech, whether that be delay, slurred speech, they're missing words, they're saying words in place of other words, that would technically be a positive. So facial drift, oh my gosh, facial droop, pronator drift, and that abnormal speech. Any are present, it is a positive.
So then if that is positive, then we move on to the CSTAT. So this is saying the Cincinnati's telling us, do we think this is a ischemic stroke or not? So that it's very sensitive to picking up ischemic stroke. So we're going to say, yes, maybe the patient has weakness and a facial droop and a little bit of slurred speech. So then if that's positive, we're moving on to the CSTAT. The Cincinnati Stroke Triage Assessment Tool is too wordy, CSTAT. So this is looking for large vessel occlusions. So we've said yes or no for stroke with the Cincinnati Stroke Scale. And now we're looking at large vessel occlusion or not. So this is going to help guide you to a primary stroke center, so whatever's closest, or if it's positive, to a thrombectomy capable center. So St. E's, UC Medical Center, Jewish, Good Sam. These patients will get, transfers take a while, so this will help get that patient directly to a thrombectomy suite. So like I said, gaze deviation, if you see that, so we're looking to one side, we're unable to cross midline, that's an immediate positive. So on the CSTAT, you're looking for 2 or greater. If the gaze deviation is there, off you go. Then you're looking at level of consciousness. So you're asking them, tell me your age and the current month. And then you're looking for commands. So you're looking at, this helps look at language, so that aphasia. So close your eyes and open them, and then make a fist and open it. And then the arm weakness you've already assessed, so you know if that's a point or not. So large vessel occlusion, we kind of went through those symptoms, things like the gaze deviation, neglect. I don't know if you've seen that before on a patient. Once you see it once, it's you kind of know exactly what you're looking for. Is they may ignore you when you're talking to them, but then they're talking to your partner that's on the other side when they're neglecting an entire side. You're also looking for aphasia. So not just slurred speech or garbled speech, but they're having difficulty saying what they want to say. They may get upset. I've seen patients cry because they know what they want to say, they just can't get the words out. Or maybe they don't understand what you're saying. I always think of it like it probably sounds like the teacher from Charlie Brown inside their head. They're just unable to understand the language. And then that vision loss is in there too. So the CSTAT is sensitive to picking up large vessel occlusions. It's an additional tool to help you rule out if we think it's a small vessel, which would do really great with tenecteplase, or a large vessel that's going to need a little bit more with a potential thrombectomy. So both those scales came from UC. They're used throughout the country. You've probably heard there's a lot of LVL tools that it was so popular there for a while. I think there's like 6 or 7. This is something we use in our area, but just keeping an eye out for those large vessel occlusions to help make a transport decision. I'll go back here to our end. Sorry for all the flipping through here. And then we did talk about a couple things that, aren't picked up on the Cincinnati Stroke Scale or the CSTAT. Those that sudden onset dizziness with other symptoms, the trouble walking, the clumsiness, things like that. If you see that sudden onset, you see that too. That's worth a pre-alert of, and how I like to word is the Cincinnati is negative, but there's a sudden onset, difficulty walking, things like that. So just keep an eye out for those posterior stroke symptoms too. And don't be afraid to let them know that there's that potential that they may need to assess them right at the door and go from there. So quickly, we are so proud and we like to share kind of the history of the UC stroke team. We were the first stroke team in the country back in the 80s. They, Art Pancioli, Joe Broderick, it was between the ER and stroke and neurology, bringing together a diverse team to help take care of these patients throughout our region. We were part of that first trial of TPA. We were the first enrollment in the 1990s. The trial came out in 1995 and it was FDA approved in 1996. And that was kind of it until 2020. Some places started using tenecteplase. But that was really it for a long time. And we were really proud of that. We were the first to use cellular technology, which is hilarious because these are the phones that we used to use. Joe Broderick would plug this into his car and take stroke call from all the hospitals in our region. We've come a long way from that. So Cincinnati Stroke Scale, the early version of the NIH Stroke Scale, which is used by nursing physicians internationally to really assess patient in the hospital. The CSTAT score, we are the national coordinating site for the NIH StrokeNet. So any stroke trial in the country that gets government funding through the National Institute of Health has to have some touch point with UC. So a lot of that is done there. I mean, we're sending out trial drug internationally. It's a huge undertaking, but allows patients, especially in our region, at all of the different Cincinnati, Northern Kentucky hospitals, access to these incredible trials that have really impacted what we're doing for patients. So we have one now called EndoLow that's looking at low, so kind of minor symptoms but they have a large vessel occlusion. If doing thrombectomy is what's best for them, we're doing something called the sister trial, which is one I'm so excited about, is looking at alternatives past TNK and TPA. So there's so many exciting things going on, and the patients throughout our region have access to that, and all the hospital systems work together to make sure our patients have access to those new clinical trials. And then we have our mobile stroke unit. We love that thing. There's only one of 3. Toledo recently closed there, so it's Cincinnati, Columbus. They all work together on that with their fire department, and then Cleveland Clinic. So we've had some huge saves. We're able to give patients Tenecta-Place in their driveway in the Kroger parking lot. We're able to help, if we do the scan and we see a hemorrhage, we're able to lower blood pressure. We're able to reverse anticoagulants. We can do different clinical trials because we get to patients so quickly. We can do clinical trials even on hemorrhages within minutes of that patient exhibiting symptoms, because once they call 911, we're dispatched. So it just adds another layer, another tool for us to take good care of patients throughout the region. So we're always excited about that. Okay, thank you. There's Joe Burrow with his interesting hair choice. But does anyone have any questions, thoughts, comments? I think every time we give a new lecture, there's an update. It's very exciting. There's so many new things coming out. I think the most important things to know is time is essential for these patients. The faster we give treatment, the better they do, the less disability that they have. And EMS is just such a big part of that, gathering information, identifying stroke. Our doctors take it at all of our hospitals in the region, take it so seriously when we hear code stroke or stroke alert from EMS. That patient just moves so much faster through the process. And all the hospitals, we've worked on that together through the Greater Cincinnati Stroke Consortium to make that a real priority in our region. And definitely not like that in other cities with all the hospital systems working together, but it does really impact the care we're able to give our patients. So I'm super proud of that. Any last thoughts, Lauren?
No, thanks for having us today. If you have any questions that you think of later, you can send them to Tony and he can get in touch with us, or reach out to us if you see us, traveling throughout the other hospitals or at some community events, anything like that. We're always happy to chat.
And if there's a topic you're interested in, if it's outside of stroke, our physicians are always willing and able. We were planning to do this at the St. E's conference, obviously got canceled. So we're excited to do that today. And especially we're so close to the Super Bowl, but fortunately the Bengals aren't there this time.
All right. Well, thank you guys so much.
Laura, Michelle, thank you very much. We really appreciate it from our end. And yeah, the idea is to try to get some of the talks that we had scheduled from the conference out there, because we felt like there were some really good speakers, and this is just a great example of education that's available out there. And we're going to try this monthly. Our next one is going to be human trafficking, and that's on February 4th at 10 o'clock. I'll send out the information on that. We wanted to try to get it in before the Super Bowl as well. As most of you know, Super Bowl was one of the prime targets of human trafficking. So we wanted to get that information out. Detective Eric Higgins from Independence, he's a international speaker on human trafficking, and he should have a really good presentation for us. So keep a lookout for that. And thanks again for everybody who attended. And thank you, ladies, for your excellent presentation.
Thank you.
Absolutely. Thank you.
We appreciate your partnership. We love St. E's and we enjoy working with you. And anytime we're welcome, we're willing and able to come back.
Hopefully we'll see you at the EMS Managers Conference in when is that? The 26th of,
Yep, you'll for sure see me. I'll be there.
all right, well, cool.
All right. Thank you.
Thank you.
Everybody stay warm and stay safe. Thank you.
All right,
You
bye-bye.
too.
Bye. Anybody got any questions or anything? Feel free to reach out to me. Tony.Shaban@StElizabeth.com, STElizabeth.com. And I'll send out a certificate if you guys want. Just send me your roster. Otherwise, you can just keep the roster for your records.